Rahul, have you joined, Dr. Rahul? I think Rahul is just joining. Rajiv sir, good evening, sir.
Good evening, Dr. Kanagavel.
Good evening, madam. How are you?
I'm good.
Thank you, ma'am. Thank you for joining. And I think, Dr. Rahul, are you with us?
He should be. He's
He is
a
here in the
message.
group. I think he is still in mute mode. He has joined.
He's joined, no?
Yes. He is in the group only.
Huh.
Rahul?
One second, I'll call him up.
I think he has some connectivity issues, ma'am.
I'll talk to.
Yes, ma'am. Kanna sir, many happy returns of the day. So please bless all of us. Sir, you are in mute mode, sir.
Yeah, thank you very much. Thank you, Dr. Kanagavel.
In spite of being birthday, thank you for joining, sir.
Tonight I'm going to Lucknow for the UPSC con.
Okay, sir. I thought you may be attending the IASG meeting, sir.
No.
In Kolkata, sir. This weekend only? No, sir. IASG meeting. Tomorrow onwards, sir.
No, last week I was in Agra for the VSI con.
Yes, sir.
That is why I could not join.
UPSC con also is happening, no, sir. UPSC con is also happening in Lucknow, no, sir?
Yeah, it is in Lucknow, yeah.
Okay.
It has started today for 3 days, yeah.
Okay, sir. Okay. Thank you, sir. I think, Rahul, are you with us, or can I ask Dr. Lydia to join, madam, first? Can she present?
Yeah, he's just joining. Give him a minute.
Then, okay. I think I will introduce the faculty to our team. Sir, we have two faculty who are now joining us for the first time. Professor Santosh Kumar Ravindran is a professor of surgery from Government Medical College, Kottayam. Thank you, sir. Thank you for joining us for the PG clinics.
Thank you, sir. Thanks.
And we have Professor Mohit Kumar Badgurjar. Am I pronouncing it right, sir?
Yes, sir. Yes, sir.
Sir is she is a professor of surgery, Geetani Medical College, Udaipur, sir. So welcome, sir, for PG clinics. We have a very senior faculty here, Professor Ajay Khanna, sir. We have Shilpa. Ajay Khanna, sir, is from BHU Varanasi. We have Shilpa ma'am from KAM Mumbai. Rajiv Sahai, sir, is from Hindurao, Delhi. We have Karnakaran, sir, from Madurai. And we have other senior faculty also here. I could see, I think few others are yet to join. Shanai sir may be joining only after 3 or 4 weeks. Jailal sir again will be out of country for 2 weeks. So we will have Rahul's presentation first. Rahul
joined,
is again,
I think. Yeah.
He's joined, ma'am.
Yeah.
So Rahul is actually he has presented once before, few months before from KAM. This time he is coming up with the mass abdomen case. So Dr. Rahul, can you share your PowerPoint and start your presentation? For the new faculty, sir, we normally allow them to run through the history, stop there and ask questions. We can go back to the slides and revisit the slides and ask questions. So we don't interrupt when they complete the history part of it. They sum up at the end of history and we ask questions. So the invited faculty take priority. And then we allow the clinical finding to be continued till the end and they arrive at a diagnosis. So the initial part of discussion goes around asking questions related to the clinical finding and how they arrive at a diagnosis. Then you are allowed to go ahead with the investigation part of it, management part of it. We have 1 hour for each case, sir. And then generally, like even it can be like an exam format. I request the examiners to kindly give the answers if the candidate is not able to answer to your expectations. You please correct it. This is like a teaching forum, sir. So please give the answers if the candidate is not able to give the right answer. And the candidates are also given an opportunity at the end to have doubts to be clarified with the national faculty. So we wish both the candidates good luck. And I should thank Shilpa ma'am for permitting the PGE from KAM in Madam's unit. And then I should also thank Professor Supriya Naik from Christian Medical College, Vellore for permitting Dr. Lydia to present this case here. So Rahul, good luck to you. Please
Thank you.
introduce your unit professors, head of the unit, head of the department, and start your presentation. Good luck to you.
Good evening, all the
Faculty, please
faculty. Hello, I'm audible.
Yeah,
Yes,
you're
you're
good to
audible.
go,
Go
ma,
on.
but we are still not able to see your slides.
Good evening, all the faculty member. I am Dr. Rahul Hemant Uike from the KM Hospital, Mumbai. My guide, Dr. Silpa
Now we are
Ramnath,
yet to
to
see
you
your
and Professor.
slides, ma.
Rahul, can you share screen, please?
Yes, ma'am. Start now. Now you can see slide.
Yeah. Good luck. You're good to go. All the best.
Yes. Next. So 35-year lady, resident of Mumbai, homemaker by occupation, nulli gravida, known case of polycystic ovarian syndrome since 9 years, came with the complaint of pain in abdomen since 1 week and fever since 2 days. Patient was asymptomatic 7 days back when she had a pain in abdomen, which is insidious in onset, right lower quadrant, mild, dull aching, present throughout the day, non-radiating to back, no aggravating and relieving factor. There is a history of mild fever since 2 days, intermittent, relief on a medication not associated with chills and rigor. Negative history, no history of abdominal distension, vomiting, constipation, obstipation, diarrhea, melena, PV bleed, jaundice, burning menstruation, weight loss, abdominal cox, lower limb edema, and abdominal trauma. Past history, there's a previous surgery of diagnostic laparoscopy and bilateral ovarian drilling with a chemoperturbation in 2011 in view of infertility. There's a history of hypothyroidism on a medication since 10 years. There's a history of previous blood transfusion in view of anemia 1 year back.
Continue, Rahul.
Yes, ma'am. Next, personal history. A patient is on a mixed diet. There is a no history of altered bowel and bladder habit, altered sleep. Family history, no significant family history. Menstrual history, menarche at the 13-year, nulli gravida, last menstrual period, 20 days back, regular for 3 days. Summary, 35-year lady, known case of polycystic ovarian syndrome, came with a complaint of pain in a right lower quadrant, noticed since 7 days, with a history of laparoscopic bilateral ovarian drilling and chemoperturbation 11 years back. So most probably abdominal cox with IC junction thickening, appendicular lump, or tuber ovarian abscess. Hello.
Rahul, can you make
Yes, sir.
such a diagnosis only based on your history?
Yes, sir. I have made a 3 probable diagnosis, sir. First is a abdominal cox with IC junction thickening with appendicular lump or tuber ovarian lump.
Only based on the history you could make all these diagnoses?
Yes, sir. Because of there's a pain in a right lower quadrant and there's a history of fever, so might be infective etiology.
No, but she has a pelvic problem. No? She has
Yes,
got some endometriosis or PCOS.
Yes.
Why all this cannot lead to the pain in the right lower abdomen and the fever? Why that is not your diagnosis?
Sir, I didn't understand the question.
You are making the first diagnosis of the abdominal tuberculosis in this patient,
Yes,
is
sir.
it?
Yes, sir.
And this lady gives the history of that she underwent laparoscopic ovarian drilling.
Yes, sir.
So it means this lady has a PCOS.
Yes, sir.
So PCOS can also lead to the pain in the lower abdomen.
Yes, sir.
Why that is not your first diagnosis?
Yes, sir. This is also a diagnosis, sir.
Okay, that should be the first diagnosis. If you want to keep any diagnosis based
Yes, sir.
only on the history, okay.
Yes, sir.
There may be ovarian cyst may be there,
Ovarian cyst.
endometriosis may be there. All these are the first thing you should think about in the history.
Yes, sir.
Okay.
Yes, sir.
What are the other probable diagnoses based on this history,
So
other than these 3?
appendicular lump, because there is also a history of right iliac fossa pain with a fever, but it is not a radiating pain.
Whether he has got any GIT symptoms?
No, sir, no GI symptom.
Then why are you thinking about appendicitis and related things?
If she is having history of pain starting at the umbilical region and now it is radiating to right iliac fossa, then I will probably make a diagnosis of appendicitis.
What are the classical symptoms of appendicitis in history?
So there is a history of acute pain at umbilical region.
May I just interrupt for a second? Rahul, can you stop moving so much? It's very distracting to everybody on the screen.
Yes, ma'am.
Yeah.
Yes, ma'am. Thank you. So there's a classical history of acute pain around the umbilicus region. After some time, pain radiating to right iliac fossa with a history of fever, history of vomiting can be present.
Does this patient have any vomiting?
No, sir. No history of vomiting.
Okay. Okay, you can proceed.
Yes, sir.
Yeah, but so he showed me this thing and I have not corrected his presentation. I just wanted him to present it as is. And I wanted this to come up because, yes, I think it is logical that he says a PID first in this lady, at least a PID first in this lady, and then maybe endometriosis and the other thing should be included. We normally do ask for a probable diagnosis after history from the candidate, so which is why he's mentioned this. But yes, he should have definitely mentioned PID and endometriosis as a probable diagnosis in addition to what he's mentioned.
Now, even if you wanted to make a diagnosis of the appendicular
Yes, sir.
appendicitis,
Yes, sir.
but you are saying appendicular lump, isn't it?
Yes, sir.
On history.
Yes, sir.
No, appendicular lump, once you have felt on examination, then it is okay.
Yes, sir.
But on history, you cannot say it's the appendicular lump, is it?
Yes, sir. I understand.
Till
Yes, sir.
this time, you only finished the history. You have not
Yes.
examined the patient.
Okay, sir.
Yeah.
Yes, sir.
After finishing the history, ideally you need not make diagnosis, but you can have a clue to which system maybe the diagnosis belongs to. So based on that system, you can put some one or two diagnoses. This is not confined to any particular system. You have 3 diagnoses. That is a problem.
Yes, sir.
And
Sir,
now
should I go?
what is this chromoperturbation?
So chromoperturbation, it is a technique to check the patency of the fallopian tube, where we inject a dye from the vaginal and we look laparoscopically if there is an extravasation of any dye.
So this the patient told you or you checked the records of this patient?
The patient told me about that. They have done to check the patency, and I also checked the document.
Okay.
Rahul,
Yes,
good
sir.
evening.
Good
Your
evening, sir.
patient is a young lady
Yes, sir.
with just pain lower abdomen.
Yes, sir.
Could you show a slide, please?
Okay, sir. Yes, sir.
Pain lower abdomen since 7 days and nothing else,
Yes, sir.
right?
Yes, sir.
Past history is, I mean, when was this done? About this laparoscopy was done, I think, how many years back?
11 years back, sir.
11 years back.
Yes, sir.
Nothing after that.
No, sir.
So, I mean, with just pain in right lower abdomen with no other symptoms, I mean, it is like looking for a black cat in a dark room, which is not there, isn't it? It's very, very difficult to come to any conclusion. Just pain right iliac fossa with nothing else, right? 11 years
With the
back,
history of
hardly
fever, sir.
has any. We would not give much of importance to that history also,
Yes, sir.
right?
Yes, sir.
So, I mean, just by history, you can say that you cannot put your finger on any sort of diagnosis with just pain right iliac fossa. There are numerous causes. You may just enumerate them, but you can't come to a conclusion here, right?
So,
Even
yes,
for
sir.
a probable diagnosis. I don't know what do others think, but this is my belief that I can't make out anything.
No, he has to give it as probably. He should have written, and he's written probably.
probably.
So he's written
Yeah,
probable.
probably
and
also.
he's
If
written-
I mean 7 days appendicular lump,
Yeah.
abscess, no. With just pain,
Pain with a fever, sir.
you've not written any other thing with fever.
Yes, sir.
No, he
I have
has mentioned.
written
Okay, in your
the-
history, you must have missed it. Okay, pain with fever. It's a
Yes,
probably inflammatory condition. Okay,
It's a
but
inflammatory.
why lump? Why lump?
Yes, sir.
It could be just appendicitis or resolving
Appendicitis.
appendicitis. Why lump or abscess?
Uh,
That's a clinical finding, right?
yes, sir. It is a
Fever,
clinical finding.
right? Abdominal cocks with ileocecal thickening. That's a investigative finding.
Yes, sir.
There should be
After
symptoms of
examination.
obstruction and kind of thing, weight loss, all that kind of stuff.
Yes, sir.
Okay, okay. I think. Look, the history is very vague. I mean, just pain and fever can mean just a plain UTI also.
Yes, sir.
Okay, let's go ahead.
On a general examination, patient examined after taking consent with adequate light and exposure in a supine position in the presence of female staff. Patient is a fully conscious, cooperative, and oriented. Average build, fairly nice, or febrile at present. Pulse 68 per minute, BP 110/70 mm in a right brachial artery. Saturation 98% on a room air. Height 170 centimeter, weight 65 kg, BMI 22.5. Pallor present, no ictus, cyanosis, clubbing, lymphadenopathy. Abdominal examination. On inspection, there is a diffuse bulge in the right lower quadrant, which is diminished on a rising neck and straight leg rising test. Rest of the abdomen appear to be scaphoiding shape. Umbilicus centrally placed and inverted, displaced upward. Hill scar present at the umbilicus, no dilated vein, sinuses, visible peristalsis, bilateral inguinal hernia site normal, left supraclavicular region normal, spine and back, no abnormality seen. On palpation, no localized rise of temperature, mild tenderness in the right lower quadrant, no guarding or rigidity.
Rahul, can you go a bit slowly, please?
Yes, sir.
I think you should breathe also in between telling your history. I don't think he's remembering to breathe at all.
Yeah.
Single intra-abdominal lump of 8 by 8 centimeters, swelling in the right lower quadrant, was reached up to right lumbar and umbilicus, margin regular, smooth, uniformly firm in consistency, lower border not palpable, upper border fell till the level of umbilicus, 5 centimeter medially from the right anterior superior iliac spine. Swelling does not move with the respiration, non-pulsatile, non-palatable. No organomegaly, no evidence of free fluid. On a percussion, dull note over the swelling, rest of the abdomen tympanic, liver dullness, which is normal in size, upper border of liver lying at the 6th intercostal space, no evidence of free fluid in the abdomen. Auscultation, peristalsis, well heard. Per rectal examination, no abnormality detected. On a per vaginal examination done with the gynec resident, there is a right pharyngeal fullness present, mass of 5/4 centimeter felt, and cervix doesn't move with the mass. So systemic examination, ANT bilaterally equal, yes, 1 CNS conscious oriented, no neurological deficit. So summary, 35-year lady with a known case of polycystic ovarian syndrome came with the complaint of pain in her right lower quadrant since 7 days, with a history of fever since 3 days, with a history of laparoscopic bilateral ovarian drilling with a chemoperturbation, lump in a right lower abdomen of size 8 by 8 centimeter, upper border reach up to umbilicus, and right lumbar region, lower border not felt. Per vaginal examination revealed right fornix fullness, most probably of pelvic origin, tubo-ovarian mass, abdominal box.
Okay.
Rahul, did you do the distal rectal examination in this lady?
Distal?
Rectal examination?
Yes, sir. Digital rectal examination done, sir.
What were the findings?
Sir, at present, sphincter tone normal, no evidence of any fissure, hemorrhoid, or stool stain. And there is no evidence of any mass felt, sir.
No, Rahul, what sir is trying to ascertain, if you press onto the lump per abdomen, do you get any change on DRE? Can you feel anything there?
I would like to feel.
No, not like to. Do you feel or not?
Yes.
Could you feel anything?
No, sir.
Did you try that? Or
I have done.
okay. Also on PV, if the lump is palpable, Was there cross fluctuation or when you push the lump, could you feel the lump moving, the same thing moving in the abdomen, or abdomen?
No, sir. It
I
is
mean, I want to see whether these two lumps are connected together or not.
Yes, sir. So, sir,
The same
on
lump.
a per vaginal examination, abdominal lump doesn't move with the per vaginal.
There's no, if you tap on it, if you push it, does the abdominal lump move along with it?
No, it doesn't move along with the
So
abdominal
they're
mass.
two different lumps.
Yes, sir. So, yes, sir. So there is a one ovarian mass with some separated collection in pelvis, like so.
So I'm
So Rahul, there are two lumps are there?
there must be a single lump, Rahul. I'm sure there's a single lump.
Yes, sir, it was a
It is
single
extending
lump.
into the pelvis, and you can feel it per vagina. And if you put pressure onto the vaginal lump, it should get transmitted into the abdominal portion. This is what I think it should be. It's very rare to have two different lumps hanging around there, very close to each other.
Rahul,
Okay.
what does that mean, that it does not move with movement of the cervix?
Sir, it suggests that it is a not ovarian, uterine origin mass.
It is not a uterine origin, isn't it?
Uterine origin, yes, sir.
Okay.
How much tender it is from the abdomen when you palpate it from the abdominal side?
So it reaches up to the umbilicus, and from intersuperior iliac medially.
No, is it moderately tender?
Mild tenderness, sir.
Is that same amount of tenderness elicitable in per vaginal or per rectal examination?
No, sir.
And you cannot palpate it with the two hands, and you cannot transmit, like ballotability, you cannot test with the one hand in vagina and one hand in abdomen.
No, sir.
And you cannot push the swelling to the pelvis. When you
Pelvis.
try to push the upper part of the limb, whether it goes and it disappears in the pelvis.
So I didn't try the test, sir.
Look, Rahul, sorry, sir. We have to find out whether this is a pelvic lump or an abdominal lump.
Yes, sir.
Now, how will you do that?
So first, I will do with whether lower body is failed or not.
Okay.
Yes, sir. This is the first test, and after on a per vaginal examination, if there is any mass can be felt or not after pushing from.
So can the lump be drawn into the abdomen cavity or not? That's the other one. Isn't it?
Yes, sir.
Right. Okay. Could we have your slide of your regional examinations again, please?
Yes, sir.
Rahul, why did you keep a possible tubo-ovarian here? Why not only the ovarian?
Why
the tubo-ovarian?
Tubo-ovarian might be ovarian mass because.
No, you have written tubo-ovarian, isn't?
Yes,
okay,
sir.
give the most obvious answer.
So might be some abscess with ovarian mass which is reaching up to the fallopian tube. That's tubo-ovarian mass.
You know, tubo-ovarian, usually it is a tubo-ovarian abscess which is there.
It's an abscess.
And and that is tender and it is not mobile. But your lump is mobile and it is just slightly tender.
Slightly tender.
Yeah.
Okay, next slide, please. Localized rise of temperature where?
At a right lower quadrant.
So if there are no skin changes, localized rise of temperature doesn't mean anything. If you find skin changes in that region, then only you can give. Otherwise, localized rise of temperature will not matter. Even if there's a appendicular abscess, you can't feel the temperature rising on the abdomen.
Okay, sir.
Right?
Yes, sir.
So
Have you mentioned anywhere that the lump is mobile? Because I can't see it anywhere in your palpatory history.
Ma'am, swelling doesn't move with the respiration at the lower.
No, is it mobile?
No.
Can you move the lump around?
No, ma'am. It is not
So
moving.
that should be written, no? That it is not moving in whichever, is it moving vertically? Is it moving horizontally?
Yes,
You
sir.
haven't
Yes,
mentioned that at all.
And this
Is
lump
is
is
it
not in the
moving or
right
not?
iliac fossa?
right lower quadrant mostly.
No, no, right lower quadrant is okay. Right
Yes, sir.
iliac fossa or not?
Yes, sir. But involving some hypogastrium and lumbar region also.
It's a large lump. Okay, right. Okay.
See, it is a lump where you are not able to palpate the lower border. And why are you very much concerned about movement with respiration?
The swelling doesn't move with the respiration.
And do you expect any such swellings to move with respiration?
So,
And you were telling 2-3 times that it is not moving with respiration.
so these are the in a general abdomen, we can see the structure which is attached to diaphragm, which can move with the respiration.
And this is a pelvic swelling.
Yes, sir.
This type of pelvic swellings, what type of movement it can have? Other than about movement with respiration, other than talking about movement with respiration, what type of movements?
Rahul, you have to tell about the intrinsic mobility of this lump.
Yes.
Before
What
you
about-
telling about the respiration, which
sir.
you have not. Can you go to the next slide? Is it written there?
No, sir.
No, you are not written.
Okay.
So before writing it with the respiration, you have to write down that what is the mobility of this lump as such.
Yes, sir. So it doesn't move on a palpation. Not moving, sir. Patient is
In any direction?
no, sir. It is not movable.
Okay.
Patient cannot.
What about renal angle? If you just have you seen the renal angles? Are they on the inspection?
Yes, sir. Renal angle I have seen, but it is there is no fullness of renal angle.
Okay. Should we? Okay. So what do you think your diagnosis is now finally? You got a lump which is with fever and tenderness. 35-year lady. Undergone 11 years ago some procedure.
So ovarian mass.
Okay. So what are the characteristics of an ovarian mass which this lump has or does not have?
So in this case, she is having history of polycystic ovarian syndrome with a history of some surgery, ovarian drilling, with a lump in the right lower quadrant with swelling doesn't move with the.
Look, an ovarian tumor should move.
Yeah.
Right? It's got a stalk, right?
Yes, sir.
I can't believe that if it's occupying the whole of the peritoneal cavity, then probably you may not be able. But this, if it's an ovarian thing, it should move. Unless it's adhering to something, it's an abscess or something. Right? Okay, let's see. Let's go on. Okay. So, okay.
Why the second diagnosis of abdominal cocks in this patient?
So I have
Points in favor of abdominal cocks.
So there's a history on a after doing some investigation, sir. I have seen that there is a.
We have not done any investigations. We are still over the clinical history and the examination.
You can say genitourinary cocks if you want to, right?
Yes, sir.
That TO mass could be you can just say it as TO mass, probably tubercular.
Yes, sir.
Right?
Yes, sir.
That would be a better option than saying just because I have investigated she got cocks, so I think it will be abdominal cocks.
You also have written particularly about IC junction, abdominal cocks involving IC junction.
So I think that's his investigations, which is
that you can just on examination, and she does not have any GI symptoms predominantly.
Yeah, you just strike it out.
Okay, sir.
Rahul, that's not done. You just strike that out. Abdominal cocks with IC is not here.
Rahul, where do you get a ileocecal lump in the tuberculosis? What is the usual site? If it is involving the ileocecal tuberculosis, hypertrophic type, what is the usual site of the lump?
At the right iliac fossa. No, sir. Right iliac fossa. It is a pulled up cecum.
Yeah, it is a pulled up cecum.
Pulled up
Okay,
cecum.
so it goes into
With
the
empty right iliac fossa.
yeah. Okay, higher up, not in this area.
Yes, sir.
Okay.
Yeah, so I think like his maybe the probable diagnosis of tuber ovarian mass stands, and instead of writing abdominal cox, if you do want to write something, you could have written the nodal involvement. You know, you can have abdominal nodes. Writing IC junction is a little
Too
it doesn't make
specific.
sense.
Too
Yeah,
specific.
yeah.
On examination. Okay, that's fine. It's okay.
Yes, sir.
Nice. Okay, let's go to how, sir, Professor
Any
Khanna.
investigations done in this patient?
Yes, sir. I have done investigation.
Okay, go to that. Yeah.
So first routine investigation. First, I have done a UPT to rule out any pregnancy. After that, HbCBC, HB 8.1, WBC 17,700, fever profile because of season history of fever, LFT, KFT. I have done. After that, I have go for a USGA plus P, which is suggestive of 5.4 centimeter into 6 centimeter of lump of ovarian origin with some multiple separated collection in a pelvis. After that, I had done CA 125 and CA and CA 19.9 to rule out any ovarian origin. So CA 125 is elevated, which is 240.9.
So what is the significance of raised CA125?
Most commonly, it is raised in ovarian cancers.
It's only in the ovarian cancer you get the raised CA125, or any other condition where you can have the raised CA125?
Most probably in ovarian cancer, most commonly 90% of.
No, ovarian cancer is one.
Yes, sir.
Any other reason where CA125 can be raised?
I have no idea.
Your patient has PCOS,
Yes, sir.
endometriosis.
Endometriosis.
In all, you will find there is a raised CA125. Though the level is not so high as that of the ovarian cancer, but they are raised in the case of the endometriosis.
Endometriosis.
And why you have done the CA99 in this patient?
CA 19.9, it is also elevated in ovarian cancer, sir. So
CA99 is more specific for which cancer usually?
GI cancer.
Usually. Huh?
GI cancer,
Which cancer?
GI, gastrointestinal cancer,
You mean the stomach cancer or intestine cancer?
intestinal cancer, and stomach cancer,
Pancreatic cancer, है ना?
pancreatic cancer. Yes.
CA99 is more for the pancreatic cancer.
Pancreatic cancer.
Rahul,
So you have written the WBC 17,700,
Yeah.
but you did not tell that what is the distribution.
Yes. Yes,
Is
sir.
it a polymorphonuclear type or it is the lymphocytes?
No, sir, I don't remember, sir.
Why is it important, Rahul? That's what I was asking.
Yes, sir.
Why do you think that knowing whether it's lymphocytosis or leukocytosis?
In acute inflammation, leukocyte increase. In a chronic disease, inflammatory disease, monocyte increase.
So, because you're thinking of tuberculosis, I think it would have made a difference. It would again, it's like a jigsaw puzzle. You got to pick up all the clues to prove it's tuberculosis, right?
Yes, sir. Yes, sir.
So, any
How do you
lymphocytosis?
know nowadays neutrophilic lymphocytic ratio, NL ratio?
And
Have you any idea about that? That
No,
has
sir.
become very common in almost many other diseases, inflammatory diseases, malignant diseases.
No, sir, I have no idea.
Ratio of neutrophil to the lymphocyte, NL ratio.
No, sir, no idea.
Okay, NL ratio is the ratio where usually it is between 2 to 3. जो है. And if you find it is higher one, then it goes in favor of the inflammatory pathologies.
Okay, sir.
And it is also related to many other, like in the case of even in the varicose veins which are there, the varicose ulcers which are there, if that ratio is raised, there is chance of the recurrence of the disease is much higher. Similarly, also in the malignant disease also. So that is coming up. Okay.
Yes, sir.
Okay.
Did you do any transvaginal ultrasound in this case?
Trans?
Vaginal
Okay.
ultrasound.
Transvaginal, no, sir, not that.
Did
Just
you try to aspirate some specimen fluid during abdominal ultrasound?
abdominal ultrasound, I will try to aspirate some fluid in a pouch of Douglas.
For investigation purpose, did you do anything? Aspirating the pus or culture or something like that?
Yes, sir. Yes, sir. I will do that.
Is it done or not?
Not done, sir.
No, do you have the ultrasound report with you, Rahul?
Not here, sir, but I have remembered that.
Okay, what can you tell us the report, please?
Yes, sir. There is around 5.4 into 6 centimeter of ovarian mass with a multi-septate collection in the pelvis of around 100 to 130 cc.
Okay. So, Rahul, there's something called RMI, risk of malignancy index in ovarian tumors, isn't it?
Hmm.
Do you know about it? Do you have an idea?
No, sir.
Well, you have the patient whether it's premenopausal or menopausal. Then you have the levels of CA125, and you have ultrasound findings, whether there's solid component, where it's irregular or multiloculated, right? And high Doppler flow. All this, if it is more than 200, is chances of ovarian tumor. Less than 200, chances of ovarian tumor is less. So with your CA125, your ultrasound findings, right, and her menopausal status, you can calculate the risk.
Okay, sir.
Just
Rahul,
one
can you tell
point on
clinically?
the presentation that I would like this thing. I mean, he's not Rahul. No, you've not mentioned any units anywhere at all. You haven't mentioned the normal CA125 levels. Then that question on endometriosis would have been answered. You can't just randomly write figures like this. No, you have to write units. You have to write the normal ratios.
Normal. Yes, ma'am. Yes, ma'am. I will.
And Rahul, if you are suspecting TO mass, then apart from CA125, what else you should have done?
So alpha fetoprotein and beta HCG level.
Yes. And LDH.
Yes,
Okay, how will you proceed? I guess you can book it.
I will do one CT scan and MRI pelvis to see for pelvic relationship with the mass.
Rahul, you did both MRI as well as CT scan?
So CT scan already done.
That come with the CT?
Yes, sir. They came with the CT. After that, we done a MRI pelvis.
Okay. So what were the findings on CT scan?
So CT scan suggestive of same finding 5 into 6 into 5.9 centimeter of ovarian mass with IC junction thickening with fluid collection in the pelvis of around 150 to 160 cc.
So could it be a sealed ileal curve with a collection, because the collection seems to be very thick walled? In
It is
your
thick one.
Yeah, so it could be probably an abscess because of perforated ileum tuberculosis. Anything? Did she give any history of any pain of peritonitis, localized peritonitis?
No, sir. Just pain.
No rectal symptoms, no colorectal symptoms,
No, sir. No colorectal symptom. No
no urinary symptoms,
No urinary symptoms, sir. Burning mutation or
because it's pressing onto the bladder also,
yes, sir.
onto the urinary bladder. So she should be having some symptoms, at least microscopic hematuria should be there.
But
Was the urine routine done?
yes, sir. Urine routine done, sir. No history
Nothing
of any
there.
occult urine.
Okay. So please.
After
What
that,
was the impression on CT scan? What did they say?
sir, it is suggestive of same ovarian origin mass with separated collection, sir, in the pelvis with IC junction thickening. No necrotic lymph node.
And etiology?
Etiology might be some ovarian cancer with abdocox. Yes.
Okay. Could you do any other investigation other than CT or MRI for this? One was the transrectal, transvaginal ultrasound, which was not done. Anything else? Any role of colonoscopy?
So colonoscopy can be done to take a biopsy, sir.
So was it done?
No, sir, it is not done, sir. We have done a MRI scan. There is no evidence of any IC Johnson thickening on a MRI.
What scan did you do?
MRI pelvis, sir.
MRI.
So there is no evidence of any IC Johnson thickening. So
you just said in a CT shows IC junction thickening.
Yes, sir.
And MRI doesn't.
Yes, sir. And they are showing that there is a
MRI is not actually MRI is not a very good investigation for GI tract as such.
Yes, sir. GI tract.
Because the thing is moving all the time. MRI takes time to acquire images, right? And the gut is moving.
Yes, sir.
So it's difficult to acquire images. Okay.
Rahul, when you do the ultrasound of the abdomen, you know what is the frequency of the probe which is used?
Yes, sir. It is around 3.5 to 5 megahertz, I think, abdomen.
And when you do the TVS, then how much is that?
It is around 5 megahertz, 5 to 7.
Around 7.5 megahertz.
Yes, sir.
If you do the transrectal ultrasound?
Transrectal, it is around, according to my idea, it is around 8 to 6 to 8.
Yeah, the same as that of the TVS, no?
Yes, sir.
Okay, so around 7.5 megahertz. If you do the breast and the thyroid ultrasound?
Breast for it is around 12 to 13 megahertz, I think.
Okay.
Or 15 megahertz.
Right. If you do the intraocular ultrasound, then how much is that?
It is 15 megahertz above.
15 megahertz. Okay. If you do the endo ultrasound, then how much is that? Gastroenterologists, they do that?
US, sir. Endoscopic.
Yeah, endo ultrasound, yeah.
US,
It's the same, around 15 megahertz, you know?
Yes, sir.
Right. What is the unit of CT scan?
Household unit.
Household. And what is the unit of MRI?
MRI, MRI. I didn't remember, sir. Just
Tesla, no?
Tesla. Yes, sir. Tesla.
Tesla. Right. Okay. So, any other investigation done in this patient?
We have done a MRI pelvis. After that,
Okay, that you've done.
yes, sir. After that, we take a gynae reference for that patient for further management because there is no any GI symptom.
So, after all these investigations, you took the gynae reference.
You should call them in much earlier. Should call them in much earlier.
Okay. And what did they say?
I think they have advised MRI pelvis. We have done it. After that, I think they will plan for surgery or some chemotherapy or to reduce the size or.
No. You have to still make a diagnosis. You have still not made a diagnosis.
Yes, sir.
Still the diagnosis is not made.
So.
Okay, Rahul, after all this rigmarole, all this going around in circles, what did you finally decide is the diagnosis?
So
we're not getting anything. I mean, even your investigations are not throwing us a clue. There's a collection and there's a TO mass. So there are two masses like we discussed, we thought so last time, right? And nothing else. CA 125 is not too high, right? So what was the diagnosis made then finally?
So mostly ovarian cancer, sir.
How will you confirm your diagnosis, Rahul?
Yeah.
We can take a biopsy.
No. Ovarian cancer, or tumor, you'll take a biopsy?
Biopsy.
No. We will aspirate that fluid, sir.
Oh. Rahul,
Yes, sir.
is there any ascites in this patient?
No, sir.
So you look, now we are not coming to a diagnosis as such. What other investigation can you do to help you come to a diagnosis? Can you do a laparoscopy, diagnostic laparoscopy?
Diagnostic laparoscopy.
Yeah, that should be done because we're not coming to a diagnosis. It is not showing whether it's ovarian tumor. It could be a malignant. It could be a inflammatory collection, right?
Yes, sir.
So we are missing some point somewhere, isn't it?
Yes, sir.
So what was the diagnostic laparoscopy planned?
Yes, sir. We can plan, sir.
No. Was it done or not done?
Not done, sir, yet.
Okay.
It's not yet done. The patient's been transferred to gynac, no, Rahul?
Okay.
Yes, sir.
Okay.
Transfer
So
to
you
gynae.
say that they took over the patient with
Yes,
the
sir.
suspicion of ovarian
Ovarian cancer.
tumor.
Yes.
Ovarian tumor. We can't say there are no lymph nodes anywhere. Are there any pelvic lymph nodes in your CT scan? None of them. None there. There's no fluid there, right?
Yes, sir.
So you're muted, Dr. Khanna. You're muted.
Why there should be leukocytosis of 17,000 in a case of ovarian cancer? 17,000, isn't it?
Yes, sir. 17,000.
Yeah. So why it is not a case of a tubo ovarian abscess? What is your first diagnosis?
Because in a tuber ovarian abscess CA 125, it is not elevated.
It can be raised. That's what I'm saying.
Can be, Rahul, it can be.
Endometriosis, there can
Yes,
be a
sir.
formation of tubo ovarian abscess.
Inflammation also it can be.
Yes, sir. Can also be there with.
So I think still probably in this patient, you have to treat it like an inflammatory mass
Yes.
or endometrial mass, rather than going for the cancer mass.
Yes, sir.
So
Rahul,
you have to make a
we are not-
diagnosis. You have to look into side in the do a laparoscope in this patient, see what is happening, aspirate from there. If the pus
Take a
is
lymph
coming
node
out,
biopsy.
go
all
send
this.
it for
I'm-
tissue diagnosis, send it for the ADA, send it for the gene expert. It may
Yes,
be
sir.
tubercular also. That is also
Yes, sir.
another possibility. Yeah.
Do a colonoscopy, take a biopsy from the IC thickening. I mean,
Yes, sir.
this patient has to be worked up. Clinically, there's nothing. Look, ovarian cancers are such which don't give any clinical symptoms until they are very large. You get it?
Yes, sir.
They have no other symptoms. They're silent. They grow silently, right? She's having fever. She's having pain. This is uncommon in ovarian tumors of this size. There should have been ascites. There should have been lymph nodes, right?
Yes, sir.
None of them is here. CA 125 should have been very high. So I have my reservations about ovarian tumors. It could be a sealed ileal perf with a collection, which is masquerading as a TO mass. I don't know. We can't say. It requires more investigation.
Yes, sir.
What about the response to antibiotics and the serial counts, total count?
Yes, sir. We have started on antibiotics. Counts reduces, sir. After that.
Still you are making a
But
The
diagnosis.
mass also decrease in size?
No, sir. Pain have been settled and infection count, WC count reduced.
Okay. So, Professor Khanna, please. We are all foxed here.
Yeah, we are all. I think, in this patient, you have to make a diagnosis and probably it's an inflammatory mass. And this patient already had a polycystic syndrome, which was there. So it may be a endometrial abscess
Cyst.
may be there, or tubo-ovarian
Endometrial
abscess
cyst.
may be there. So, and as you say that by giving the antibiotics, the count is coming down. Okay, so this patient has to be treated like that. But the laparoscopy will give you the diagnosis.
Yes, sir. Diagnostic lab.
Yeah, I would like to put this across to all the other examiners also. I mean, I would personally give a diagnosis of an inflammatory lesion there, rule out tuberculosis because that's this thing. But I felt like saying CA in a patient like this is a little too ambitious. What are your thoughts on that, Dr. Santosh, Dr. Mohit, I think Dr. Ajay Khanna has also already mentioned that you should send ADA and all. But what are the thoughts on this as a candidate? How should he, what would his first diagnosis ideally have been?
His first diagnosis ideally should be some inflammatory lesion like abscess, tubo-ovarian abscess, or pelvic inflammatory disease producing abscess, or sometimes related to some salpingitis producing local abscess. So all this history is leading to something related to some pelvic gynecological pathology, leading to some inflammatory condition, resulting in some pelvic abscess. So if you were trying to do a pervaginal elicitation of tenderness, you should have very well done aspiration through the fornix to get the pus. And if the pus is frank pus, you should have even tried for drainage through that area, which should have resolved the condition because it is already responding to antibiotics.
Yes, I also agree with Santosh sir. Right from the beginning, the history is short. Fever is there for 3 days. Along with that, tenderness is there. Counts are raised. So everything is suggesting in the favor of some abscess in the abdominal cavity, and if lump is palpable, some surgery has been done, and all the findings are definitely suggesting of no chronic pathology like tuberculosis or something like that. It should be the first diagnosis, and yes, TO mass is a safe thing to say in examination.
Yeah, Rahul. My feeling would be, I would say that it's a proof that it's a pelvic lump, probably inflammatory. I will not commit to any diagnosis till further investigation. It could be, it is inflammatory, but the original inflammation is still open.
I mean, at the most, he could have said that he would like to rule out a malignancy after the whole thing is done. But I think the primary diagnosis should have been an inflammatory mass and to rule out tuberculosis in the process. And so this is what happens when, they look at investigations and they look at everything and the papers and everything, and then they stop thinking in a rational manner. If he didn't have the diagnosis, probably he would have told you all this. But because that's fixed in his head, he's roaming around in that sea, So Rahul, again and again, I keep telling you guys, don't look at the diagnosis, don't look at treat it as a clinical history and exam and take it from there. But they don't listen to me, so I'm hoping they listen to all of y'all. And yeah, so.
In your examination, you'll be asked about the mass, you'll be asked about the investigations, you'll be asked what are the options to prove your diagnosis. I don't think you'll be asked any question on the diagnosis as per se.
Yes, Shilpa rightly said, when you answered Rajiv sir's question about the movement when you push it through pelvis, through vagina, and you said yes, it is not the upper mass is not moving when I push the mass in vagina, and you said it could be two masses, one is septated collection. There you were definitely guided by your investigatory findings. So never look at the investigatory findings, just stick to your examination findings.
Yes, sir.
Okay, I think well done, Rahul. Though tough case. Ovarian tumors are always a challenge for even gynecologists. For a surgeon, it's an enigma most of the time. So tough case.
Yeah, if she's lucky, she'll just end up with having some inflammatory disease and
hopefully
do well.
She needs more investigations, I'm sure.
So
She needs.
Yeah.
Do they do diagnostic laparoscopy at your place? The gynecologists. They do.
But so but I think that so what happens is most times they will come to us in general surgery and as a abdominal pathology, and then we'll do the baseline investigations, and then the patients would get transferred to the gynac side. And I don't think my boys really go and follow up what happens.
I think they should. It's an interesting case.
Yes,
they
should. Yeah. But they don't.
Get a colonoscopy done. Get a laparoscopy done before they jump into removing the tumor.
Yeah. So I think the gold standard would be a lab, a diagnostic lab, and establishing tissue.
And transvaginal also.
I think they should have done that, but yeah.
Sir, Professor Khanna, should we move to the next case, sir?
Thank you, sir.
We can.
Thank you.
Okay, Rahul, always see the clinical findings first and the history and all those. never see the investigation first. If you see the investigation first, then you will always make a diagnosis that there is the IC thickening is there. Okay,
So your
never see
mate
that.
is trying to sing
Yeah.
happy birthday to you.
Okay, thank you. Okay. I think we can close here and we can go to the next case now.
Yes, sir.
Dr. Kanagal there?
Not there. Dr. Lydia,
Yes, sir. Good evening, all.
good evening.
Yes.
Just share your slide, please.
Yeah, sure, sir.
I think we'd request Dr. Shilpa to stay back, Professor Shilpa. Because I think a case of breast, I think, isn't it?
I'm there. I'm there.
Right, right, ma'am. Yeah, go on, Dr. Leah. Please share your screen, please.
1 second, I'm not able to share. 1 second, sir.
Just open your slide first and then go into share screen.
Rahul, Shilpa ma'am is there?
Yeah, I'm there.
Yes.
I'm there. I'm around.
Okay,
I'm just
okay.
waiting
Ma'am,
for
you
her
want to
to
stay
step.
back for the next case, ma'am?
Yes, we requested
I'll
her.
be around. I'll be around. Yeah.
Okay, okay. Ahil, how do you call you, Dr. Lydia? Lydia Rajan?
Sir, Ahil or Lydia, anything is okay.
Ahil, okay, fine. Faculty should know because your name is little unusual. So faculty, I think we will go ahead with the second presentation.
Yes, sir.
Can
please.
you give me 2 minutes, sir? I'll log in from another one. I'm not
Okay,
able
okay,
to.
come back. You use your colleague's laptop or this thing, ma'am?
Okay, sir, sure. 1 second.
Shilpa ma'am, it is a case of CA breast.
Yeah.
That's the reason I requested. But I'm sorry if you are otherwise committed. I think.
No, I'm around. I'm listening.
Thank you, ma'am. Thank you. Thank you. Thank you.
Not
Shilpa ma'am, I've sent you the PowerPoint,
Which PowerPoint?
the girls' PowerPoint.
Oh, okay. All right.
So you can run through because.
Yeah. I think she can just read it through now if it's not getting connected.
No, ma'am, I think her computer is not supporting the PPT. That's what she says. But the PPT is important for the faculty, ma'am. Give me 1 minute, ma'am.
இல்ல ஏதாவது ஞாபகம் இருக்கா தெரியாம தான் கேட்டேன்
Sorry, faculty, for this delay. Very sorry. Ahil, are you okay? Dr. Rahul, can you do me a favor? I will send her PowerPoint to you. Can you project the slides for her? Is that possible? Dr. Rahul?
I think Rahul is also gone. No? Is he there?
No, I think he, do you have any challenge, Dr. Rahul? Can I send the PPT to you? Can you project for her?
I'll call him.
Please
sir,
in mute mode. Can you do
Yes,
that?
sir.
Sorry for asking this help, because that will save
I can
all
do,
of
sir.
us time. I'm sending it to you, Rahul, right now.
Okay, sir.
It is
Yes,
already
ma'am.
sent.
No, take it. I was just calling you up for that. Go on.
It is sent to you, Dr. Rahul. Can you try playing it? Dr. Ahil, you please switch on your video. Dr. Ahil,
I think it's
I'm not sure who is sharing, Ahil or Rahul. Rahul, are you sharing or she is sharing?
Yes, I am.
Okay,
Try to
okay.
share.
Okay. Thank you, Dr. Rahul. You go to the first slide. Dr. Ahil Lydia, are you with us?
Yes, sir.
Dr. Ahil?
Yes, sir.
I'll call. Dr. Ahil?
Dr. Kanadeval. Maybe you can call her up and tell her that the screen is available and she can just come on.
Madam, I'm
audio.
calling, ma'am. I'm calling, ma'am. I'm
Yeah.
calling another number.
Yeah.
Hello, sir. Can you hear me?
Yes, you can go ahead.
Ahil?
Yes, sir. Can you hear me,
You're
sir?
okay. Dr. Rahul will be projecting the slides for you.
Sir,
So you can start.
Sir, I'm able to share my screen now.
Okay, try doing it. This is your screen or Dr. Rahul's screen?
It's mine, sir.
Okay. Make it full screen. Introduce your unit chief, your head of the department, and start your presentation. Good luck to you.
Thank you, sir. Hello.
Faculty, kindly take over. You
I'm
make it
asking-
full screen. Sorry?
Yes, sir.
You have some challenges? Rahul, is that your slides or Dr. Lydia's slides, Dr. Rahul?
No, Dr. Lady's slide, not mine.
Her slide only.
Yes.
Okay. Well, can you start your presentation, Dr. Lydia?
Yes, sir. I'm Ahil Lydia Rajan. I'm doing my postgraduate in general surgery in Christian Medical College, Vellore. I'm presenting a 45-year-old lady, tailor by occupation, residing at Arcad Ranipet, who presented with complaints of lump in the right breast for 7 months. She was apparently well till February 2022, when she sustained trivial trauma to her right breast in February 2022, following which she developed pain in the right breast and incidentally felt a lump in the right breast in the size of a coin, which progressively increased in size.
Dr. Lydia, hang on. Your slides aren't moving.
Lydia, I think you please unshare yourself. I request Rahul to do it.
Oh, okay, sir.
Okay.
You please stop sharing. Dr. Rahul, you can try sharing, Dr. Rahul. Sorry for again inconvenience.
Yes, sir. I can do, sir.
Yep. Thank you, Dr. Rahul. Make it full screen, and whenever she is done with the slides, you can help her to advance the slides. Very sorry for putting you into this task, Dr. Rahul.
Yeah, I can do, sir.
Yep.
Yeah,
Go
next
ahead, Dr.
slide.
Lydia.
Yes, sir. So she
Rahul,
developed.
change the slide, please. Yeah, that's it.
Pardon,
Next
sir?
slide. No. Rahul, next slide, please.
Yes, sir.
Yeah, now go on, Lydia.
She was apparently well till February 2022, when she sustained trivial trauma to her right breast, following which she developed pain in the right breast and instantly felt a lump in the right breast in the size of a coin, which progressively increased in size over the last 3 months. She also had history of mild retraction of right nipple since puberty, with significant retraction over the past 3 months. And there was history of itching over the nipple areolar complex, which increases during menstruation since childhood. There is no history of nipple discharge, no history of redness, no history of dyspnea, hemoptysis, hematemesis, jaundice, backache, bone pains, abdominal distension, altered bowel habits, melena, headaches, seizures, syncope, menstrual irregularities, or fever. There is history of recurrent shoulder pain present left more than the right, which was treated with analgesics. There was no history of any known comorbid illness. No history of use of contraceptives or hormonal therapy. Personal history, she consumes mixed diet. There is no history of sleep disturbances. She has a normal appetite with no loss of weight. Bladder and bowel habits were normal. There is no history of smoking, consumption of alcohol, tobacco use in any form, or drug abuse. And she belongs to upper middle class family. Menstrual history, she's unmarried, nulli gravida, and her last menstrual period was 13th of September 2022, and she attained menarche at 13 years of age. Her cycles were regular, 28 to 32 days cycle with 2 days flow, and there is history of occasional spasmodic dysmenorrhea with passage of clouds present. There's history of excessive whitish discharge per vagina present, not associated with foul smell, itching, or lower abdominal pain. Her mother had breast cancer, unilateral, underwent mastectomy at her 40 years of age when the patient was 10 years. And she also received adjuvant radiotherapy. She was treated in CMC Vellore, but the details of the treatment were not available. And her mother succumbed to illness 35 years ago, that is 6 months after her mastectomy.
Please wait, Dr. Lydia, and the examiners will ask questions.
Can we go to the first slide, Rahul? Her first slide on history.
Yes, ma'am.
No, go on. Next. Okay. So a couple of points here, which I am a little concerned. When you say size of a coin, Lydia, it doesn't mean anything at all. So, there were times when anecdotally we should ask them to, this thing it to balls, like, because balls have specific sizes, but you can say approximately so many centimeters. I don't understand by the size of coin what you're trying to say. And you've mentioned everything about nipple and everything, and then you've straight away gone on to systemic complaints. You've not mentioned anything about lump or fullness of axilla, supraclav area. You've not mentioned anything about ascites, which is also a common ailment. So there are a lot of points that need to be added to the history to understand the progress of the disease. So this needs to be made a little more in detail. Yeah.
Ma'am, actually, I have some internet issues. I am not able to hear you. What did you say, ma'am? Please, can you repeat it, ma'am?
No,
I
no.
love this. I love this. I have no energy to repeat this again.
This
Can
is
you
like
hear me now?
losing your presentation without saving. This is like losing your presentation without saving.
Yeah, this is not really acceptable, darling. But can you hear me now?
Yes, ma'am, I can hear you. I'm sorry.
Okay. So my first point of contention was you're mentioning it in terms of size of a coin. I have no idea what coin you're talking about. So I have no idea what the size of the lump was. So you can probably say it in terms of approximately so many centimeters. She will show you in her hand how much it was. So you kind of just go and say it is so many centimeters, or it's this size or whatever, and then approximate it. Secondly, you went to right breast, you went into the right nipple, you've mentioned nothing about the opposite breast, you've mentioned nothing about the axilla, you've mentioned nothing about the supraclav region, you've mentioned nothing about ascites, I think. Yeah, so I mean, there are multiple points in your history which still need to be added to make it a complete presentation.
Okay, ma'am.
You heard me now?
Yes, ma'am.
Okay.
Another thing which I would like to add, Lydia, is
Yes, ma'am.
mild retraction of right nipple. Retraction of nipple since puberty. What would you call that? It's retraction. Then what is the difference between recent retraction and retraction at, or whatever it's called? What is it called? Since puberty? Nipple retraction, okay? This would be
Yes.
indrawing of the nipple.
Okay, sir.
Right?
Yes, sir.
So if there was retraction, then the significant retraction over the past 3 months.
Yes, sir.
Right. Okay, no nipple discharge, redness. Redness over where?
Over the breast.
So no change in color, okay. Next slide, please. Okay,
Yeah,
next.
go on. I think you can move on.
Yeah, next slide. Next slide. So other than lump, she's got nothing, and a very strong family history. Okay,
Yes,
next
sir.
slide. And she's unmarried, no children.
Yes, sir.
So what are the
Can
risk
you-
factors?
Yeah,
Right.
can you tell us, enumerate all the risk factors in this
Lady
lady?
has.
Yes, ma'am. Family history of breast cancer.
Mm,
Then she's a nulli gravida.
yes.
So that's also a risk factor.
Which is the strongest risk factors amongst this?
Family history, sir.
Right. What about the age?
Yeah, that's it.
Breast cancer is more common in more than 40 years of age. And
No. Do
She's
you want to
45.
know the age of the mother when she had breast cancer?
Right.
Is that
Early.
important?
Early.
At 40 years of age. Actually, I made some changes in the slides, which I have, but it's
Lydia,
not
we
there.
can't read your mind, na. We have to
Yeah.
see what is available and ask you accordingly.
Yes, ma'am.
Yeah. So you need to tell us at what age the mother had breast cancer. How is that important?
She was 11, you said, I think, when the mom had succumbed.
She was 10 years of age and her mother was 40 years of age.
I can't hear you.
Her mother was 40 years old
40
at that.
years. So is that considered a higher risk factor as compared to if her mother had it later in her age?
Yes, ma'am.
Do you know the step ladder, pattern of risk in family?
No, ma'am.
How do you up the risk of breast cancer? You can climb up a ladder. So what is the baseline risk, and then it keeps climbing up? And you need to know this because breast cancer is so common.
Yes, ma'am.
Yes.
I'm
Tell
not
us.
sure.
You tell us
Okay,
of what you
tell
know.
us whatever
then
you
we'll
know.
complete
Tell
it.
us whatever you know.
Means how much increased risk she is having since her mother had CA breast.
That is 50%. Plus, she's also an early gravid. So it will.
50%. Just the mother having breast cancer at 40 makes it 50% risk for her to get breast cancer. Is that what you're saying?
Yes, ma'am.
It is
Even
not
if she had
percentage.
malignancy in the other breast, it won't be 50%. You get me?
So Lydia, you have to start with the number of relatives having breast cancer, the relatives on the mother's and the father's side. You mentioned nothing about the father's side or the mother's side in the history at all. Okay, so that is one thing. If it's more than if it's one relative, then the risk is like, it's at level 1. Then if it's 1 to 3 relatives, then the risk, it's up to one more level. If any of those relatives have had breast cancer below the age of 50, or have died of breast cancer, or have had bilateral breast cancer, then that really ups the risk to about 60 to 70% of it being maybe a hereditary kind of thing. So you have to have a detailed history on all aspects of what you're mentioning.
Okay, ma'am.
Yeah. Okay, go to the next slide.
You have to ask about the family history of other cancers like ovarian cancers also in this case.
She's not mentioned a lot of stuff. Yeah. Ovarian, prostate, thyroid, every cancer you have to ask for. They're all into the picture now. Mother's side and father's side. Right?
Yes, ma'am.
Yeah. Go on to the next slide, Rahul. Yeah, so your history really needs to kind of be worked on. Yeah, and add all these points that we mentioned. Okay, you also have to talk about history of whether she has put on weight, her BMI is high, low. Okay, you mentioned that but history of any recent weight gain, even in premenopausal women, is considered a possibility. So all those things in history you need to mention.
Okay, ma'am.
Yeah. Start your exam. Lydia?
Yes, ma'am. On physical examination, on general examination, she is conscious and comfortable. She's thin built and moderately nourished. Her height was 141 centimeter, weight was 53 kg, with BMI of 26.6 kg per meter square, an ECOG performance score of 1. There is no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or edema. Her heart rate was 102 per minute in right radial. It was regular with normal volume, and BP was 130/80 millimeters of mercury in sitting position, and respiratory rate was 18 per minute thoraco-abdominal, and she was afebrile. On examination of the breast, after informed consent and in a well-lighted room with adequate privacy, with the arms by the side and sitting position, breasts were examined. Breasts were hemispherical. Right breast was slightly larger than left breast. There was no redness, puckering, dimpling, prominent veins, or purity orange. There was mild edema present. The skin over the breast was normal. There was no visible lump, nodules, ulceration, or fungation. And both the nipples were present and at the same level. Right nipple was retracted and deviated daily. There was no accessory nipple cracks or fissures. There was mild eczema present. Area symmetric bilaterally. No cracks, fissure, ulcer, or discharge. No axillary or supraclavicular illness. On palpation, there was no local temperature. There was 7 to 8 centimeter well-defined solitary hard retroareolar lump with mild tenderness fixed to the breast tissue, not fixed to the underlying muscles and in chest wall. Nipples couldn't be averted and there was no discharge gentle pressure. Left breast was firm and lumpy. There was a single non-tendered firm 2 to 2 centimeter right axillary lymph node with mildly restricted mobility. There was no left axillary or supraclavicular lymphadenopathy. Chest wall and arms were no palpable nodules or skin thickening. On systemic examination, respiratory system bilateral normal vesicular breathsounds were heard, no added sounds. CVS S1, S2 plus no murmur. She is well oriented and no focal neurological deficits. On abdominal examination, there was no umbilical nodule, no abdominal mass, no palpable liver or free. Vertebral long bones, no tenderness. Examination, no nodules or mass, and pervaginal examination was normal. To summarize, a middle-aged gravida of breast
Rahul, move on to the next.
presented with progressive solitary hard retroareolar right breast lump with nipple retraction and palpable right axillary lymph node and lumpy firm left breast. Probable diagnosis is malignancy of right breast axillary lymph metastasis. See T3N1MX and probable left breast fibrosis. Ma'am, I have actually wrong. That's not T4B, it's T3N1 and MX.
So it's changed since the time you made the presentation. You've given. Okay, again, can we go back to your? So the first, yeah. Okay, so you are telling me this nipple is retracted. I'm a little skeptical. It's been there since some time, so I would call it an inverted nipple. So how would you know the difference?
If it is genital or it can be inverted, but it cannot.
What is the technique used for?
Lydia, if you can just exit
getting
from
the-
your video. Sorry, Lydia, if
I've
you
just
could
gone
exit from your
audio,
video
yeah.
so that your audio is
Better,
audible.
yeah. What is the technique that one uses to, you know, re-retract, make the inverted nipple normal? What is, there's a maneuver which is used. Are you aware of it? Lydia, if you don't know, it's easier. You say it and then we'll progress further, because then your time will be up and we would not have done anything beyond this.
Ma'am, I'm not sure of the manual exact one.
It's called the Hoffman's technique. Okay, go read it up. It's a methodology to kind of figure out if that nipple is actually involved or not involved. Or of course not in this case, but you can try it and figure out whether there is a duct which is pulling the nipple. In a CA breast, it will be part of a nipple which is pulled. It's not really retracted, usually in most cases. Okay, again, you haven't mentioned anything about the left breast at all in your entire exam. Go next.
Ma'am, I mentioned in the examination.
Is firm and lumpy.
Firm and yes, ma'am.
Okay, but you need to mention that whether there is, firm and lumpy means what? Meaning, are there multiple lumps?
It's diffusely rubbery
So
consistency.
it's nodular. It's nodular.
Firm.
It's a nodular consistency. Okay, when you say lumpy consistency, it could still be something else. So use specific words when you're talking. So you can say it's firm yet nodular. Okay. And you haven't mentioned where the axillary lymph node is, whether it's level 1, level 2. Go next. Go next. Okay, so again, you need to mention in far more detail about your findings in a systematic, detailed manner about your findings so that we get a good picture of what you're trying to say. Correct? Yes,
Yes,
Lydia? Okay. So now do
Yes,
you want to rephrase your summary again?
A middle-aged nulligravida with progressive solitary hard retroareolar right lump with nipple indrawing and
No, you can say
other right axillary.
you've forgotten one of the most important adjectives in this summary. You not
Gender.
need to mention her menopausal status.
Yes, but she's still menstruating. Yeah, I should have mentioned it.
So she's premenopausal, but you have to mention it.
Yes, ma'am.
Henna, that is going to be your
Yes,
actual, it's going to decide what you're going to do with the patient. So it has to come in your summary.
Yes, ma'am. Yes, ma'am.
Okay, so you're saying this is a T3 and one M0, MX.
And
Okay.
Yes,
How will
ma'am.
you proceed?
Ma'am, I'd just like to ask.
Yeah, I'm sorry, go on.
Yeah, Lydia, first of all, your BMI, the patient's BMI is 26 something, which is not. Second, how do the nipples in the breast move on raising the arm? Is there any restriction in movement? No, just don't show me the
There
slide. Yeah, don't show the slide. Yeah. How does the breast move? Do the two breasts move similarly in similar fashion when you raise the arms? Is there any difference in the position of the nipples? Is the lump, does the lump become more visible on raising the arm?
No,
You
sir,
get
there
me?
was no significant in the
Are there any lumps in the axilla visible on raising the arm? What about the undersurface of the breast? Look, Lydia, these are basic examination points which you have to come and get across. Now, answer ma'am's question. How do you proceed?
imaging, ultrasound, and
Lydia,
mammography.
Lydia, hang on. Just exit. Just stop your video and continue with the audio. You're not being able to hear you properly. Yeah, go on.
Okay, sir.
Please answer Dr. Shilpa Roy, please. Rao, please.
Sir, I would like to do a true cut biopsy, ultrasound of the breast, and mammography.
No, just put it in sequence. Don't shuffle up. Don't shuffle them up. True cut. First core biopsy. Not you should say core biopsy rather than true cut. True cut is a trade name.
What is the word you're going to use? If the examiner hears that word, those two words, we know what you're going to talk about. So what is it that is always associated with a lump in the breast?
The triple assessment.
Yes, you have to say you will conduct the triple assessment. So you've done the clinical breast exam. Then what will you do?
Pathological. I'll do a true cut biopsy of the lump.
You'll do a biopsy before you do radiology?
No, ma'am, only after the imaging.
So what imaging will you do in her?
Ultrasound breast and mammography and other imaging.
Why do you want to do both of them? A mammography is a gold standard. Huh? Okay,
yes,
so
because she's a nulligravida, the density of the tissue will be more, and
right. Okay, that is one. What else would you do an ultrasound for?
To look for axillary lymph nodes.
Okay. So what will you see on an ultrasound that that will indicate malignancy for the breast lump?
Hypoechoic lesion, speculated margins.
Hypoechoic.
Yes, ma'am.
What else will you look for?
The margins.
Okay, irregular. You can't say, you call them irregular. Then
Yes, ma'am.
what else would you look for?
Ma'am, infiltration to the underlying muscle.
Okay, what else? Lydia, if you start from you finish describing the lump, I don't know how much hypoechoic or whatever, then you talk about the margins, then you will talk about the width and the height, then you will talk about the skin, then you will go on to the nipple areolar complex, and then you will go down to the muscle. So go in order so you don't forget what is, and you'd also look for other lumps in the breast. You would look for lumps in the opposite breast.
Yes, ma'am.
Yeah, and you would look for the opposite axilla as well.
Yes, ma'am.
And you would look for the supraclav area as well. So all that is covered in your ultrasound.
Yes,
Do you have a mammography picture?
Yes, ma'am. I have one.
Tell me.
The mammography showed a heterogeneously dense fibroglandular parenchyma with high density mass lesion with ill-defined margins in the central quadrant of the right breast, with large hypoechoic mass with speculated margins in the periareolar region.
Continue.
And on the left side,
Yeah, go on, go on. Just
fibroglandular.
What else were you doing the ultrasound for, Lydia, other than the breast?
For axillary lymph nodes, ma'am.
So what is there? What can you see in the axilla?
There is a axillary. There are multiple axillary lymph nodes.
Where?
In
Which
the axillary.
Huh?
On the right side, ma'am.
I can see even on the left side, a pretty large node. In fact, the left side node looks bigger than the right side. Oh, the right side, yeah. You can see a lymph node on the left side as well. Can you not?
two small ones and one large one.
Yeah.
Ma'am, actually, it is less denser than the other lymph nodes. So
Okay, Lydia, hang on. Do you know what are the malignant features on mammogram? What are the features they're going to look for in a mammogram, which will tell you?
High density lesions with ill-defined margins, speculations, microcalcifications.
Okay, what else? Anything with the skin? Anything about the architecture? Anything about the lymph nodes?
So cortical thickening.
Ma'am, I think you should take over.
Okay, so I'll make it easy. I make it very easy for my boys. So you start with the ABCD. A stands for architecture. Okay,
Yes,
B stands for the breast lump, which you describe in details. First, you mention whether the architecture of the breast is maintained or not. Then you talk about the lump itself, and you talk about the speculated margins and the. You can see actually the nipple. You also need to show me the other view, where you'll see the nipple areolar, the craniocaudal view, and what is the other view?
The mediolateral oblique view.
Yeah, show me the other one. Show me the. Yeah. अभी इसमें उल्टा दिख रहा है.
It's not taken properly, I think. Anyway.
Yeah, so you can see a little thickening there at the nipple area, which is not seen on this side. The nipple seams inside. Then you go to C for calcifications. Then you go to D and talk about the density of the breast. Because if the breast is dense, then just doing a mammography may not help. Sometimes you can miss lesions 10% of the time, even more in dense breast. Then E, you go into the extra breast tissues. So you look at the axilla, you look at the muscle, underlying muscle, you look for anything outside of the breast. Yeah. And
Yes, ma'am.
F is for fat planes. So if you go in that order, you'll be able to describe the entire mammography in a complete manner. Right?
Yes, yes, ma'am.
Okay. So now after this, you've done what have you done after this?
Ma'am, core needle biopsy was done. That showed invasive ductal carcinoma.
So you only do a biopsy. You don't want to do an FNAC of anything?
No, ma'am, because it's a large lump and past history of trauma was there. We did a core needle biopsy.
I didn't ask you breast lump. I said, do you do an FNAC of anything at all?
FNAC of lymph node can be done to rule out metastasis.
It is not
ma'am.
can, you have to do it, na?
Yes, ma'am.
And what else can you do when you're doing the FNA? Or the biopsy? Is there any additional thing that you can perform at that point in time?
The supraclavicular lymph node.
No.
If present.
No, for the breast lump and the axilla, is there anything that you can do while you're doing an ultrasound?
I'm not
While
sure.
you're doing, when you're doing the FNAC guided FNA, or you're doing a core biopsy, is there any additional thing that you can perform?
As ma'am, tag the lymph node.
Then tag the lymph node, right? And you can also maybe put a clip into the breast lump, maybe not such a large lump, but if you have the facilities, you should be doing it for both.
Yes, ma'am.
Yeah. Okay. What is your biopsy report?
Biopsy showed invasive ductal carcinoma, histological grade 2, ER/PR negative and HER2 positive.
Okay, so what does it tell you? How will you progress?
Because it's a T3 lesion with an N1, I would like to do start with neoadjuvant chemotherapy.
What kind?
Here we give epirubicin cyclophosphamide with docetaxel plus trastuzumab because it is HER2 positive.
So you'll give all of them together?
No, ma'am, 4 cycles each. Of epirubicin cyclophosphamide and docetaxel.
And Herceptin you give by itself?
Pardon, ma'am?
Do you give Herceptin by just Herceptin by itself, or do you have to add something to Herceptin?
I'm not sure of that. I'm sorry.
Yeah, you need to add a taxane to it, na?
Yes, ma'am.
There are also these trastuzumabs because taxanes improve the efficacy of the trastuzumab in a NACT setting, right?
Yes.
Okay.
Lydia, sorry.
Yeah, go on.
You said grade 2. You said grade 2. What do you mean by histological grade 2?
The moderately differentiated.
Can't hear you.
Yeah, you're lost.
Moderately differentiated carcinoma.
What kind of carcinoma?
Moderately differentiated.
Moderately differentiated carcinoma. Okay. So you've given her chemotherapy. What are you looking for?
Now, how will you know whether the chemotherapy has worked or not, Lydia?
Usually the size of the lump decreases
Okay. And suppose
And-
it's not decreasing.
Pardon, sir?
Suppose the lump is not decreasing. Anything else?
How will you know response to chemotherapy? What are the various factors that will predict a response to chemotherapy?
Usually the size of the lump decreases.
No, Lydia, you don't have to say it like that. You have to say it in like a clinical response and radiological response. Okay. You should not say
Okay,
that
sir.
size will decrease. What ma'am is asking. I guess ma'am is also ma'am also want to ask that.
Thank you for reading my mind. Okay, and give yourself some pause there. There's another thing that I would, you say she's hormone receptor negative and HER2 positive, 3+. Is there another investigation you should have added to this?
Genetic study, gene testing.
If she is HER2 positive, 3+ HER2, which is the likely site that HER2 malignancies metastasize?
Usually,
This was asked by ma'am last class also.
I keep asking the same
Yes.
questions.
This was asked. So you all should be attending these classes. Then get to know the questions. At least revise them before you come. All on the net. Okay.
So it's brain, and there's a lot of work happening in the retina as well. So you need to do a fundoscopy and you need to do a brain scan, preferably an MRI.
yes, ma'am.
Yeah, 30% of HER2 at initial presentation would have brain mets, right?
Yes, ma'am.
Okay, so you've given chemo. Now, how do you gauge the response?
As well as the clinical and radiological
Yeah,
response.
so now you expound on it. Now he's given you hints. Now you need to progress on that. Tell me, what are the clinical signs that show response? What are the radiological signs?
Clinically, the size of the lump decreases and the
Meaning,
heart.
how much does it
How much? How much?
reduce? What is the percentage in reduction that is required to be seen?
At least 50%, ma'am.
Now, if it is complete response, what do you mean? What do you mean by complete response?
The swelling the lump is no more palpable.
Right, the lump disappears completely. What is partial response?
At least 50% of
No,
the
30%.
30%.
And what is no response or progressive disease?
Either the lump remains the same size or increases in size.
By 20%. So it's 0, 30, 20. Okay.
Okay, sir.
Rest, go on.
Okay, so this has shown a good response. It has now, after your 4 cycles of all of those things, it has become less than 1 centimeter in size now. The axilla seems to be clean. So now how will you progress?
Modified radical mastectomy with or without breast reconstruction.
Why do you want to do a modified radical?
Because she has a strong family history.
By that standard, you should do a bilateral mastectomy.
Yes, ma'am.
There are multiple papers now, Lydia, which show the superiority of a breast conserving surgery which has shown such good response. Now, because it is on the nipple areola complex, is there any kind of oncoplastic procedure that will help you maintain the cosmesis of the breast?
Regional flaps,
What flap would you use?
latissimus dorsi or
No.
Trump.
Oncoplasty. I'm asking you about oncoplastic procedures. If you're doing a BCS for a lump which is 1 centimeter, why do you need to use an LD flap?
In BCS, it's not required, ma'am.
Hmm?
In BCS, it's not required.
I thought-
Augmentation mammoplasty can.
You said the lump is it's a
Lydia,
central lump.
ma'am. Lydia, don't
Yes,
commit
sir.
harakiri. Don't contradict your examiner. If you don't know, say don't know, right? If
Yes.
she's asking you that in BCS, what do you do? She knows. Obviously she is asking you something she knows about. Don't say
Yes.
it's not there in BCS. Never do that. That's harakiri, and we sent away.
Yes, sir.
Oh, she said that. I didn't hear it. I'm lucky for her. I didn't hear that she said it can't be done. Okay. So you can do a Grisotti's flap, which is a very simple flap to, which you can do for a lump like this. And if there is no evidence of, okay, what are the indications on your biopsy that will tell you that, no, I don't want to do a breast conserving surgery for this lady because you don't agree with me. So tell me, what will you find on a biopsy that can strengthen your case against mine?
If it is triple negative,
It's
and
not. This patient is HR positive, negative, HER2 positive. I'm not asking you, I'm talking about this particular patient.
her MIB index is more than 30%, 30 to 40%.
So, it's 30%. 30% is, what else on a biopsy would tell you that maybe, just maybe, she may not be a candidate for BCS?
For this patient or in general?
Yes, we are talking about this patient. Why would I talk generally?
Yes, ma'am.
So you look for DCIS. Okay, so if there's extensive DCIS, then that's still not a contraindication because you'd still do a BCS and look at the margins. But
Okay.
yes, if you tell me that there is extensive DCIS, then I might still consider your answer. But other than that, an MRM is really not a standard of care anymore for lumps which have responded well to an ACT.
Okay, ma'am.
Okay, so now you've done surgery. Whatever surgery you finished doing, you've done it. Then what?
She requires adjuvant maintenance.
Sorry? How will you address the axilla?
Ma'am, adjuvant chemo radiation.
You will radiate the axilla?
The breast, ma'am. The chest.
So I'm asking you, Lydia, please listen to the questions the examiner asks you. If I'm asking you something and you go randomly somewhere else, you will only exasperate the examiner. I very specifically asked you, how will you address the axilla in this patient now that the axillary lymph node has disappeared?
If we had placed a tag, we can selectively dissect the lymph node.
Meaning only the tag lymph node you'll dissect?
Or intraoperatively also, we can inject dye.
What dye would you inject?
Methylene blue.
Okay. If you're doing a BCS, you know what happens when you inject methylene blue? Have you ever done a methylene blue injection?
No, ma'am.
You can get severe necrosis of the skin. Is there a more elegant method of finding out the axilla?
Radioactive label
What is it called?
Technician.
You can use ICG.
Okay, ma'am.
Yeah.
Yes, ma'am.
And if you don't have any of these facilities available, there's still something you can do. What is it called? Surgically, you can do something. It looks like मेरा ही exam हो रहा है. मैं ही question पूछ रही हूँ, मैं ही answer दे रही
आंसर कर रही हूँ.
No wonder Dr. Kanadi will ask me to stay. You do an axillary sampling. Do you know what that is? See, all the examiners have put their hands to their heads. Yeah. Lydia, answer something. Chalo.
Go,
Yes,
Lydia,
ma'am.
go. Take a stand.
Are you still there?
Yes,
Please
ma'am.
switch on your video, ma.
Lydia, what is axillary sampling?
It's all.
Okay, Lydia, suppose you have to choose a lymph node to sample in axilla. If you don't have these kind of ICG and stuff, which lymph node will you choose?
The central group of lymph nodes.
You'll choose the largest one, won't you? Lydia?
Yes, sir.
It may be in any group. You just choose the largest one. Is it?
Yes,
It's
sir.
okay? Right.
Yes, sir.
So you would do an axillary sampling, Lydia. Go read it up now because I'm getting tired of hearing my own voice. But you know, if nothing else is available, you do an axillary sampling where you have 4 lymph nodes between the second intercostal and the angular vein, and you send that sample of fibrofatty tissue, find out whether any of those lymph nodes are positive, and then proceed to do a complete axilla. Okay, that's
Okay,
how
ma'am.
you address the axilla. Once you've completed your surgery, what is it? What is the next step?
Follow up the biopsy, and if it shows any residual malignancy, we'll go ahead with adjuvant chemo radiation.
But you've already given her the whole arma mater that you have. What else can you give her?
Maintenance trastuzumab.
It's not called trastuzumab. A is not chemotherapy. What do you call trastuzumab?
What are they, trastuzumab? What are they? They are
What's the
Monoclonal,
huh?
monoclonal anti-human epidermal growth factor.
So what is that therapy called? It's not called chemotherapy. What is it called?
Immunotherapy.
There's a better word for it.
Immunotherapy, ma'am.
It's called targeted therapy.
Okay, ma'am.
Yeah. And
Yes,
there are
ma'am.
multiple types of targeted therapies. That how long do you give trastuzumab after post adjuvant trastuzumab?
For 6 months.
Is there a question mark after that? Again, you are asking me a question, so I can answer. You should never ask the examiner questions. That's our prerogative.
Yes, ma'am.
52 weeks at an interval of 3 weeks.
Okay, ma'am.
Anything else you'd like to give her?
No, ma'am.
Other than you don't want to radiate her?
If it is, yes, ma'am. I want to radiate
What will you radiate?
the chest wall.
What is mantle radiotherapy?
Lydia, look. You're getting bold by every question, right? So there's a way out for this. Either you say no, or you say, I will discuss it with the tumor board. I'm not supposed to know everything about everything, right? So you should, when you're fighting a war in not winning, you should surrender and say, yes, I don't know, I'll read about it. Just say no, right? These awkward pauses and all, they don't do any good to you, right? It's always more elegant to say.
No, but I think the reason why breast is discussed so often is because A, it is the most common cancer, and B is because in every exam, one out of two people will get a breast cancer case. And you cannot today say that you don't know the basic tenets of management of breast cancer. You have to know it. So this much is absolute basic. I'm not asking you multiple targeted therapies. I'm not asking you for, there are so many things, we've not progressed beyond the basic, the absolute basic questions that have been asked. This have to be known. Everything else is much beyond of it. So that hasn't even come into the picture today. So Lydia, you need to be better prepared when you come to a forum like this, so that you come and learn from this forum, right?
Yes, ma'am.
Yeah. So read about this thing and be very clear as to how you will progress.
Okay, ma'am.
Okay. Is there anything else you would like to give her?
Adjuvant chemotherapy also.
Huh?
Adjuvant chemotherapy also.
But you've already given her 4 cycles and 4 cycles. How much more can you give? Okay, tell me a little bit about genetic testing. I think that will be my last question. It's already beyond time.
BRCA1 and 2 mutation analysis. Then to look for other syndromic associations to.
What other ones?
Like Leaf-Remini syndrome.
No. Which other genetic testings do you do?
P53. P10 and CDH1.
Check inhibitors and PAL-B. Do you know the importance of PAL-B?
No, ma'am.
Okay, this one you go and read up. Okay, it is therapeutic as well as clinical significance that it has.
Okay,
okay, I'm done. I think Dr. Kanagaran, all yours.
Thank you. Dr. Mohit, and you would like to add any questions or give your comments?
I think Lydia was more prepared with modified radical mastectomy only, and she was not expecting BCS, which ma'am has changed completely. And this is the message I want to give to all the PGs, that you should not be sticking to your diagnosis, because situation can change. Any examiner can give you a hypothetical situation and completely change your preparation. So you should read it thoroughly, and breast is something which should, which, as ma'am said, it is very commonly asked in exams, and you should be thoroughly prepared with that, especially recent advances in breast.
Thank you, sir. Dr. Karnaharan, sir, any comments, sir?
No comments, sir.
I think Ravindran sir is already
I would like
clear.
to say something, sir.
Please, sir. Sahay, sir, please.
Right. Look, Lydia, this examination is of, say, half an hour, right?
Yes, sir.
You'll have to do they will test you on your history, examination, and your basic management. This kind of advanced this thing goes only when you answer the basic questions. Only then the examination will progress to this level, right? But in theory, you will be asked. In recent advances, you will be asked. So like ma'am said, you have to know everything about 4 or 5 malignancies, which are very commonly asked in the exams. You must know everything about them, right? And this is one of them.
Okay, sir.
Right.
All right. All the very best.
Sir, please.
And
thank you, Dr. Shubha ma'am. I think I pulled you at a hard hour and made you to stay. Thank you very much for accepting our request. And I also thank Mohit Kumar sir and other senior faculty here for making this event a possibility. So next week, we have a case of a soft tissue tumor and possibly one more abdominal lump. So I will share the details shortly. Thank you, Shilpa ma'am.
Yeah, thank you and
all
good
the
night.
Yeah, thank you so much. Thank you. Good night.
Good
Good
night.
night, madam. Good night, sir.
Namaskar.
Good night. Good night. Dr. Mohit, if one of your PGs can present in subsequent week Fridays, we'll be happy to have them on board.
Okay, sir. Okay.
Thank you very much. Thank you. Faculty, with the permission, I'm closing the thing. And I thank Dr. Rahul and Dr. Lydia for coming up for the presentation. Rahul, special thanks for you to staying back for sharing the PowerPoint. Thank you very much.
Thank you, sir. Thank you, sir.
Thank you, Dr. Hill. Thank you, everyone. Good night.